Welcome, everyone, to this deep dive for KMR advice. We try to break down complex topics here, giving you those insights you really need.
Indeed.
And today, we're tackling something fundamental: the heart's electrical system, how it works, and importantly, how medications actually interact with it. This is, well, pretty essential stuff for understanding cardiovascular health, and especially how drugs work. Very relevant for you folks following KMR advice on your medical journey.
Absolutely. And we're going to structure this based on, the core ideas of cardiac electrophysiology. We'll be pulling from resources like cardiac electrophysiology and drug actions.
Right.
Our mission, let's say, is to really build that foundational understanding. How does the heart generate and conduct electrical impulses? And then how do different cardiovascular drugs actually impact those processes?
Exactly. And for everyone tuning in to KMR Advice, we're tailoring this to be clear, step-by-step, just what you need for your studies.
Yeah.
So if you find this helpful, please do hit like, share it around, and subscribe to KMR. Advise for more explanations like this one. Oh, and hit that bell icon too so you don't miss out.
Definitely helps us keep making these.
Okay, let's jump in. Maybe start with the big picture. Cardiovascular drugs themselves.
Good place to start. So cardiovascular drugs, broadly speaking, they treat heart and blood vessel disorders. Simple enough, right?
Yeah.
But how they act? Well, there are kind of two main ways. They can work directly on the heart or blood vessels themselves.
Okay.
Or they can work indirectly, influencing other systems that then affect the cardiovascular system. Think the autonomic nervous system, the kidneys, even some local chemical messengers, autocoids, they're sometimes called, like local hormones almost.
So it's not always hitting the heart directly. Interesting.
Precisely. And just to give some examples of drug classes, you've got antiarrhythmics for rhythm problems, inotropes affecting how strongly the heart contracts,
Right.
vasodilators widening blood vessels,
Yeah.
and diuretics dealing with fluid balance and blood pressure. But to really get how these work, you absolutely need to understand the heart's own electrical system first.
Okay, yeah, that makes sense. So cardiac electrophysiology, what are the absolute cornerstones we need to know?
There are really four fundamental properties. Get these, and you're well on your way to understanding drug actions. They are impulse generation, conduction, excitability, and refractory periods.
Impulse generation, conduction, excitability, refractory periods.
Each one is critical for normal function, and crucially, each can be a target for drugs.
Let's start with impulse generation then. How does the heart actually start these signals? Where do they come from?
Well, the heart muscle, the myocardium, it has two main kinds of fibers. We call them non-automatic and automatic fibers.
We're non-automatic and automatic.
And their ability to generate impulses is, well, very different.
Okay, and unpack that for us. What are the key differences we should remember?
Right, so non-automatic fibers, these make up most of the atria and ventricles. They have a stable resting potential around minus 90 millivolts. And the key thing, they cannot start an impulse on their own.
They need a trigger.
Exactly. They fire when an impulse arrives from somewhere else. Now, automatic fibers, you find these in special areas like the SA node, the AV node, the His-Purkinje system.
Pacemaker areas.
Precisely. And what's special is their resting potential isn't stable. It slowly drifts upwards, spontaneously depolarizes during what we call phase 4.
Phase 4 depolarization.
Yeah, it creeps up until it hits the threshold, and bam, it fires a new impulse. So these guys are the heart's natural pacemakers. They set the rhythm.
That's very clear. Automatic fibers set the pace because their resting state isn't really resting.
Yeah.
What about the action potential phases themselves? Are they the same in both types?
Not quite. I mean, both depolarize and repolarize, obviously.
Sure.
But that phase 4 is the big difference, stable and non-automatic, slowly rising in automatic. And another key thing, the rapid upstroke, phase 0, in non-automatic fibers. That's mostly fast sodium influx. In automatic fibers, especially the SA and AV nodes, the phase 0 is slower and driven mainly by calcium influx.
So different ions driving the initial spike, sodium versus calcium. That makes sense.
And that difference is fundamental.
And that leads perfectly into the different types of action potentials you mentioned earlier, fast and slow channel.
Exactly right. Those two types map directly onto the fibers we just talked about. Fast channel APs, that's your atria, ventricles, Purkinje fibers.
Sodium-driven ones.
Yep. Rapid depolarization, high amplitude, fast conduction, like 0.5 to 5 meters per second, fast. And importantly, their effective refractory period, the ERP.
The time they can't be re-stimulated.
Right. The ERP is usually shorter than the total action potential duration, the APD. And blockers. Think tetrodotoxin or local anesthetics for those fast sodium channels.
Okay, got fast channel APs. What about the slow channel ones?
Slow channel APs, these are mainly in the SA node and the EV node. And as we said, the ion driving their slower phase 0 is calcium.
Calcium.
Right, so you get slower depolarization, lower amplitude, much slower conduction, maybe 0.01 to zero point 0.1 meters per second. Big difference.
Huge difference.
And interestingly, their ERP is often longer than their AKD. The selective blockers here are key drugs: verapamil, diltiazem.
Calcium channel blockers.
Verapamil, diltiazem, okay.
So it's fascinating, right? The heart uses these two distinct electrical systems, fast sodium, slow calcium, to coordinate everything. This electrical duality is really key to understanding heart rhythms and drug targets.
So the speed, the characteristics, it all depends on the ions involved and the specific location in the heart. Now, you mentioned conduction velocity. What exactly controls how fast these signals travel?
Good question. It's primarily determined by something called membrane responsiveness.
Membrane responsiveness, okay. And that depends on two main things: how fast phase 0 rises the slope, or dVdt we sometimes say, and the resting membrane potential itself. Think of it as how ready the cell is to pass the signal on.
Okay, let's dig into that. How does the resting potential affect speed?
Well, the resting potential determines how many sodium channels are actually available and ready to open. If the resting potential is less negative, say neckage to 70 milliV instead of a neckage to 90 milliV, then more of those sodium channels are already inactivated. They're not available. So when the impulse arrives, fewer channels open, the phase 0 upstroke is slower, and conduction slows down.
Like some dominoes were already knocked over, so the chain reaction is slower.
That's a great analogy, exactly like that.
So how do drugs play into this? You mentioned sodium channel blockers like quinidine.
Precisely. Drugs like quinidine directly block some of those sodium channels. This reduces the slope of phase 0, flattens that rapid upswing,
Slows it down.
which directly slows conduction velocity. And that's really useful for treating certain arrhythmias where you have abnormally fast pathways causing chaos. Slowing them down helps restore order.
Right. Strategically slowing things can fix rhythm problems. Okay, let's shift to excitability and the refractory period. What are these concepts about?
Okay. Excitability. Simply put, it's how easily a heart cell can be triggered to fire an action potential. It's about the stimulus strength needed.
Makes sense.
And resting potential matters here too. If a cell is hyperpolarized, more negative than usual, it's further from the threshold, harder to excite, decreased excitability.
Okay.
Conversely, if the resting potential is less negative, it's closer to threshold, easier to excite, increased excitability.
In the refractory period, you said that was crucial.
Absolutely critical. It prevents chaos, basically. The effective refractory period, ERP, is the minimum time after one beat before the cell can respond to another propagating beat. It's a rest period, a time of unresponsiveness.
The reloading time?
Exactly, the reloading time. Now, the relationship between this ERP and the action potential duration, APD, is different in fast versus slow channel fibers.
How so?
In fast channel fibers ventricles, atria, the ERP, is usually shorter than the APD. But in slow channel fibers, the AV node, the ERP, is often longer than the APD.
Longer?
Yes, and that difference is really important for understanding arrhythmias and drug actions. Many antiarrhythmics work by lengthening this refractory period, extending that reloading time to prevent misfires or stop those chaotic reentrant loops.
Okay, so different parts of the heart have different reloading times, and drugs can manipulate that. That makes sense. Now, the heart isn't working in isolation, right? There's the autonomic nervous system.
Oh, absolutely. The autonomic system, sympathetic and parasympathetic, is constantly tweaking cardiac function, including all these electrical properties we've discussed.
Can you give us a kind of side-by-side, sympathetic versus parasympathetic effects?
Sure. Sympathetic stimulation, think adrenaline, fight or flight, generally speeds things up. It increases automaticity in the SA node, so heart rate goes up, tachycardia.
Right.
It shortens the refractory period, speeds up conduction, and increases the force of contraction in both atria and ventricles. It's the accelerator.
Accelerator, okay. And parasympathetic.
Parasympathetic, think vagus nerve, rest and digest, does pretty much the opposite. It decreases SA node automaticity, slowing the heart rate bradycardia.
The brake.
Exactly, the brake. It prolongs the refractory period, especially in the AV node, slows conduction, and decreases contractility, mainly in the atria, though. Its effect on the ventricles is pretty minimal.
So accelerator and brake, constantly balancing each other out to meet the body's needs.
Perfectly put. It's a dynamic balance. Now, let's tie all this together. the clinical implications, especially for our KMR advised listeners. How do drugs actually use these principles?
Yes, this is where it gets really practical. How do those drug classes we mentioned earlier actually change these electrical behaviors?
Okay, so basically, cardiovascular drugs work by tweaking one or more of those four properties: impulse generation, conduction, excitability, or refractory period.
Right, let's go through them. Impact on impulse generation.
Okay, think about heart rate control. Beta blockers, they block sympathetic effects on the SA node, slowing down its automaticity. Result, lower heart rate, great for hypertension, some arrhythmias.
Beta blockers slow the SA node.
Got it. Then you have calcium channel blockers like verapamil or diltiazem. They act strongly on the AV node, slowing conduction there. This is really useful for supraventricular tachycardias, where you need to slow down signals coming from the atria.
Okay, so different drugs target different nodes for rate or rhythm control.
Yeah.
What about drugs affecting conduction velocity more generally?
That's primarily the sodium channel blockers, like quinidine we talked about. They slow conduction in atrial and ventricular muscle by blocking sodium influx during phase 0.
Right.
This slowing can disrupt the circuits that maintain arrhythmias like atrial fibrillation, helping restore a normal rhythm.
And altering excitability. How do drugs do that?
Well, drugs like amiodarone, which actually affects multiple channels. One key action is increasing the refractory period by making the cells unresponsive for longer.
Extending the reloading time.
Exactly. It reduces overall excitability, makes it harder for stray, early beats and topic beats to trigger a sustained, dangerous rhythm.
Okay. And targeting the refractory period itself.
That's where potassium channel blockers come in. They specifically prolong repolarization, extending the ERP. This is really effective against reentrant arrhythmias, those loops of electrical activity. By extending the refractory period, you essentially break the loop because the tissue ahead isn't ready to conduct yet.
This really clarifies how these drugs work at the electrical level. Now, we have this table here, which is super helpful for the KMR Advise audience, linking specific drugs to their effects. Can we walk through a few examples?
Excellent idea. Let's solidify those connections. Take quinidine first.
Okay, quinidine.
Target: sodium channels, electrophysiological effect, slows conduction velocity, clinical use, atrial fibrillation, other arrhythmias.
Makes sense. Next, propranolol.
Propranolol, target: beta adrenergic receptors, effect: reduces automaticity, slows heart rate, decreases contractility. Use: hypertension, angina, arrhythmias, especially those driven by sympathetic tone.
Versatile drug. Amiodarone. You mentioned its effect on refractory period.
Right. Amiodarone, key target we'll focus on here. Potassium channels, effect:
Okay.
prolongs refractory periods significantly. Use: serious ventricular arrhythmias like VT or VF.
Okay, verapamil, the calcium channel blocker.
Verapamil, target: calcium channels, especially in the AV node, effect: slows AV node conduction velocity. Use: supraventricular tachycardias where the AV node is involved.
Got it. And finally, digoxin. You said its target was different.
Yes, digoxin targets the NA plus ADVK plus ADAGI AT pace pump. Bit more complex, but effects include increasing contractility, positive anosmia, and slowing heart rate, partly via the vagus nerve. Use: heart failure, controlling rate, and atrial fibrillation.
That walkthrough is great, really connects the dots for everyone following KMR advice. We also have that summary table of autonomic effects. Maybe just a quick recap of those differences before we finish.
Absolutely. Quick recap. Sympathetic increases heart rate, speeds AV conduction, increases contractility, shortens refractory period. The accelerator.
Yep.
Parasympathetic decreases heart rate, slows AV conduction, decreases contractility, minimal ventricular effect, prolongs refractory period. The brake.
Perfect.
And remember, many drugs work by influencing this autonomic balance too.
Okay, wow. This has been a really thorough deep dive. We covered a lot of ground today, especially for the KMR Advise audience.
We certainly did. We went through impulse generation, conduction, excitability, refractory periods, the autonomic influences, and crucially, how different drug classes target these electrical mechanisms to treat heart conditions.
And this knowledge isn't just academic, right? It's absolutely vital for anyone in medicine to understand why these drugs work and how to use them properly.
Couldn't agree more.
So for all of you dedicated learners tuning in to KMR Advice, we really hope this detailed explanation has given you a clearer picture of cardiac electrophysiology and drug actions.
Hope it was helpful.
If it was, please remember to like, share it with colleagues, and subscribe to KMR Advise for more deep dives like this. And hit that notification bell.
Yes, please do. And maybe a final thought to leave you with, particularly for students.
Oh, yeah.
Consider how changes in electrolytes, potassium, sodium, calcium levels in the blood might affect all these electrical properties we've discussed. And then think about how that could change how well these drugs work or even increase their risk of toxicity.
Ah, that's a really important point. The interplay between electrolytes, electrophysiology, and drugs. Definitely something crucial to explore further in your studies.
Exactly. Lots more to learn.